would like also to remind the presenters, given the fact that on Friday we normally have some other events that happen in the afternoon as part of the closure, we would like to push you a bit, and we do it quickly so that we are not got up by time. So, Dr. Kenneth, you are welcome in front. I haven't seen the other colleague. You're okay, Margaret. Matlida Kwayamba. Oh. Okay. So we can make this arrangement that we can invite Peter Mikagu, so that Kweyamba we can contact her and we'll be able to do it online if she's. The presentation is ready. Okay, so we start with her. We start with the people who are within. Okay, thank you so much for the guidance. The team members, hopefully the members, the ones online are with us. You are most welcome. So we take this opportunity to invite the first presenter, that is Madame Nalukenge Margaret. Thank you.
Good morning, members. I'm Nalukenge Margaret, Senior Nursing Officer from Rural Hospital, and the co-author there's Dr. Innocent Nkonwa, Sister Florence Namuyanja from Luwero District Local Government, and Flavia Mbekeka from Maldimay, Uganda. My presentation is on assessing maternal and perinatal death surveillance and response in Luwero District. Comprehensive emergency obstetrical care services are essential component, MCH component, and when failure or inadequacies occur in a SIMOCO system, poor outcomes persist. Some of the contributing factors which can lead to these poor outcomes, it can be the gaps in functionalizing theater, especially in health center force and the hospitals which they are just promoted. Junior staff are not consulting the senior staff. There is delay in initiating care, and you find that poor outcomes also can persist due to faulty equipment and delayed referrals. As we know that most maternal deaths are preventable, so maternal perinatal death surveillance and response is important in the reduction of maternal perinatal death. Another slide. So, the DHT and extended DHT SAT and reviewed the DHIS2 data for the financial year 2018-2019, which showed that maternal death audit in Luwero district were at 64%, while the perinatal death audit we were at 0%, which was quite low to the Ministry of Health standards, which is 100%. So because of the gaps which we identified, we sat as a team and set the objectives. One of the objectives were to increase on the maternal death audit in Luweero district from 64% financial year 2018-2019 to 100% financial year 2019-2020. And also another objective, we wanted to improve on the perinatal death audit from 0% financial year 2018-2019 to 50% 2019-2020. What was our methodology? Our methodology, actually the study was for a period of 1 year. It started in June 2019 to July 2020. It was implemented in 36 facilities. 31 health center theories, which are implementing basic emergency obstetrical care. Then 3 hospitals and 2 health center force implementing comprehensive emergency obstetrical care. The cross-section design study was employed, and we used both quantitative and qualitative data collection technique. As we were reviewing our data, we found that we had 17 maternal deaths and 137 perinatal deaths, which were reviewed and audited. And the quantitative data, which was from the past documents, actually, the quantitative data, we got it from the past documents, which were reviewed, analyzed against the Ministry of Health notification and review standards using the Excel computer software. After identifying the problem, after identifying our gap, we had to sit and find out the root causes to the problem. And one of the root causes which we realized, it was the knowledge gap among health workers, lack of guidelines to constitute the maternal perinatal death surveillance review committee. We were lacking tools, especially the notification and the audit tools, including the guidelines for MPDSR. Also, we found out that there was poor scheduling of duties and poor prioritization of staff were not prioritizing work. So we made the tested changes or the proposed changes to see that we work on the problem. The proposed changes which we made, it was to revise the scheduling of duties so that we can have more than one staff on duty. Sensitization of health workers, and our emphasis was on the midwives, nurses, doctors, and clinical officers. Then also we proposed to constitute and functionalize the MPDSR committees, both at the district and the facility level, or requisitioning of tools from Ministry of Health, which I've mentioned above. So after making the proposed changes, we had to prioritize which change can we start with. We prioritized our changes using a matrix system, and we said that the change which will score high, it is the change which we shall start with. In this case, with the matrix system, we found that at least sensitization of the health workers scored high, as you can see. We want that slide, please, for the matrix. Continue with the slide. Yes, prioritization. We used the matrix system, And we found that sensitization of health workers scored high, being followed by the constituting and factionalizing the MPDSR committees, and then ensuring consistency in requisitioning of the tools for Ministry of Health, revising the staff, the schedules of duties. So we went in that order to work on our problem. As we implemented, what did we achieve? What were our results? Can we look at the slide for the results? As you are seeing the bar graph, this bar graph is on the maternal death case notification and audit in that financial year of 2019-2020. The first bar is on the notification. Actually, as I said earlier, that we reviewed 17 maternal deaths. We notified 17 maternal deaths in that year, and we were at 100%. Out of 17, 16 maternal deaths were audited, and we were at 94.1%. And out of the 16 maternal deaths, 6 were audited on time, that is 37.5, and 10 were audited late, that is 62.5. Another slide. Then with the perinatal death, we notified the 100%, that is 156 perinatal deaths, and out of those, 137 were audited on time, that is 87.8, and 19 were unaudited. That was a gap of 12.2. Can we go to another slide? As you are seeing, as you have already seen our results, what made us to achieve the notification 100% and the audit of 94.1, it was the sensitization of the health workers and functionalizing MPDSR committee, and what made us not to audit on time, it was the staff workload, staff absenteeism, and the poor prioritization of work. Can we go to another slide? In conclusion, generally the district achieved its objectives. However, there was still a challenge of timeless auditing, which we are prioritizing to work on this financial year of 2020-2021. We are recommending that MPDSR should be used to improve the maternal and neonatal outcomes, and also adoption of the QI methodology, quality improvement methodology, should be used to improve service delivery in other sectors in the district. Lessons learned, thank you very much. Lessons learned, orientation of the health workers. We saw that it was very important because it helps us to reduce on the negative attitude of the health workers, because at first they thought that reporting MPDSR committee is legal proceedings will be put against them. Teamwork is very important, and auditing of maternal and perinatal death helped identifying some service delivery gaps which were addressed to prevent reoccurrence. We acknowledge the support. Can we go to acknowledgement slide? The support given by PEPFAR, CDC, Ministry of Health, 7th Uganda, and the Rural District local government. Thank you very much.
Thank you so much, Margaret Nalukenga. Thank you so much. We are tight with time, but we need to be reminded that we shouldn't lose the content, and also we need to just bring out those key points so that we don't lose your information which you wanted to share. Thank you so much. I would like to invite Dr. Kenneth Mutesasira as the next presenter. Dr. Mutesasira is taking us through improving the national TB treatment outcomes using the continuous quality improvement approach. He will introduce himself. Thanks.
Thank you, Session Chair, for this opportunity to share these early experiences of improving the national TB treatment success rate using quality improvement approaches. I'm glad to be associated with other presentations that have already been made at this conference in relation to improving TSR. As we wait for the slides, my name is Kenneth Mutesasira, and I work on the USAID Defeat TB activity as the Senior Technical Advisor. And the USAID Defeat TB activity is a national technical assistance mechanism that aims to improve case notification and treatment success rate in the country. We work at national level, but also collaborate a lot with the regional teams and the regional referral hospitals. So that is the outline of the presentation. Next slide, please. Yeah, so as a bit of introduction, the global target for TB treatment success rate is 90%. However, as you will note in our past NSP, the country stagnated for years at 72%, and the problems were mainly around high loss to follow-up, deaths, and patients that are not evaluated. And the new NSP actually has a target of 90%, and we are working towards that. So the National TB Leprosy Program, with support from Defeat TB and other partners, set up an improvement initiative to be able to address this gap. Next slide. So in terms of the methods, we started with formation of the team. You're going to hear a lot of the principles applied as we did this work. Formation of a multidisciplinary team at national level, and that involved the program team, it involved the IPs, it involved academicians, it also involved CSOs and TB survivors. And that team was tasked with a role of conducting a root cause analysis, but also synthesizing what is working, because not the whole country is performing poorly, but some regions are actually performing fairly well. So the team conducted a root cause analysis, synthesized some guidance, and also developed a roadmap for improving this TSR. So that was followed with dissemination of this guidance and the roadmap to the regions, with guidance for each region to be able to identify the priority facilities using the Pareto principle, and then to be able to implement this package, which we are calling the retention package. I'm going to share it shortly. And then thereafter, the team continued to do some joint targeted support to the regions, as well as monthly meetings to review progress. That is the roadmap, and the roadmap highlights what I've said: national level work at the regions. We are still between stages 3 and 4. You note that we are behind for the common reasons, the factor of the interruption of implementation activity. Next slide, please. So in trying to understand the problem, the team identified the primary drivers if we are to achieve 90% TSR, and those are outlined in that visual, starting with retention. And retention has secondary drivers as well, but we had retention, monitoring of treatment response, adherence support, working with data, and early linkage. And each of those has secondary drivers. And so as teams work to improve, they are working around those processes to be able to close the gaps, as I'm going to highlight. Next slide. Now, in terms of understanding the problem of low TSR, from all those processes I've described, we identified low retention as the top problem. As you can see on the graph on the left-hand side, Patients who start treatment, we note that they drop from care along the continuum of response, along the 6 months. So if you started with 10, for some of the facilities, you still find they end up with 4 at the end of 6 months. So there were issues with retention, weak clinical systems, delays that we have just heard from the patient-centered care presentation, issues of lack of appointment systems, lack of community engagement to support patients and to track them, incomplete recording in the registers, but also limited leadership engagement to really be able to demand for accountability. Next slide. So we also talk to the patients that are dropping out of care. This is data from about 55 patients within Kampala, Wakiso, and Mukono who dropped out of care. They were traced and returned. And the blue graph shows the common reasons for dropping out of care. And as you will note, they highlighted lack of transport as the top reason, travel for social reasons, either for work or for visits, side effects, some felt better, but also lack of food. Those were the top reasons that the patients gave. There are several others that I may not go through now. Now, I recognize that different regions have actually undertaken the root cause analysis with their patients, and some of these reasons vary. For example, in Karamoja, the lack of food is top on the list. And I know that Lira and the Acholi have also conducted these. The graph on your right-hand side shows some of the suggestions that the patients made. And reminders were top of the suggestions: reducing waiting time at the facilities, delivery of medicines in the communities, support with transport and food. So in that order. So again, as I mentioned, depending on the region, the needs might differ, but this is information that the facility teams can use to devise mechanisms to hold their patients through care. Next slide, please. So this is the package of change concepts, and behind each of the bullets you see there are different changes that the teams can test, and the aim of the working group was to have this guidance so that teams can go around and test. The first is TB patient engagement and support throughout the course of treatment. The key point is throughout the course of treatment, not at the beginning, and then we look for results 12 months later when the patient fell out. And there are different modalities that can be used. The other one is the improving clinic efficiencies, making sure the appointment systems, their clinic days, their monthly retention and mortality audits to make sure patients are not dying. The other one is community engagement to perform the roles that I've already mentioned: patient education, patient tracking, those who miss appointments, work around data quality, completing records on real time. That includes the patient refill, the sputum results, and also the outcomes, because patients complete at 6 months, but the outcomes are reported 12 months later. So real-time recording of those outcomes. And leadership engagement, we think this is key. We have seen it works in regions where dashboards are shared and the DHO and the regional teams are able to demand for accountability for these patients. Next slide, please. So in the results, I'll just flash a few sites using dashboards. You can see that dashboard, the red is 70% and less, TSR. 71 to 84 is yellow, and above 85% is green. You can see from those sites listed a shift from red towards green. This, as I mentioned, is early work, and we hope to continue tracking. These are just some of the sites that are being supported to do this work. Next slide, please. We see the same picture for the regional referral hospitals. As part of this effort, regional referral hospitals and a few other high-volume facilities have been selected for additional support from the central team. And again, we see a shift, gradual shift from red and yellow towards green, and we'll continue monitoring and we'll have more results as we go along. Next slide. So the national level picture has moved as such. This effort started about April to June 2019. That was like the baseline. And as you can see, we have moved almost 10 percentage points. If you compare April, June 2019 to April, June 2020, and even July, September, 2020. Next slide. So I think this speaks to the same, but this is how we are looking at the data, looking at the regional shift. We have a mild shift if you look at the map on your left. That was the year before, and the map on the right, we are seeing some shifts from yellow to green, some reds to yellow, but there's still a lot of work to do in the central region and the northeastern region that we are tracking. Next. So in terms of the lessons that we are seeing is that the quality improvement approach can be applied at governance level in addition to other levels to be able to achieve to optimal treatment outcomes. But there is need for sustained skills building for quality improvement in the regions. This is part of the experiences we see. And there's also suboptimal implementation. So if we have uniform implementation, we shall hit that target. And so the recommendation is to scale up this TSR improvement package using the quality improvement approaches, and for us to continue supporting all levels at direct service delivery and the support for improvement. I think this should be the last slide to acknowledge the Ministry of Health, all implementing partners, because you do this in the regions, the CSOs, the healthcare workers, TB patients, and the USAID Defeat TB, not forgetting USAID for the funding. Thank you very much.
Thank you so much, Dr. Kenneth Mutesas. You can take a seat. And we'd like to remind the colleagues, the audience, that the discussions will be happening shortly after Dr. Matilda Kweyamba has made her presentation. So the colleagues, the IT team, would you kindly connect us to Matilda? Thank you.
I'm a PPM coordinator, that is public-private mix for TB approach, and I work with the National TB Leprosy Program under the Defeat TB project. I'll be discussing the engagement of the private health sector in TB care prevention that we did carry out through a quality improvement collaborative approach, and the results I'm going to be sharing are from Uganda. The 2015 Uganda National Prevalence TB survey showed that 37% of presumptive TB patients did seek care initially from the private health facilities. However, we know that in as much as the first point of care is the private health facilities that are private, many of these remain unengaged by the National TB program. And in addition, they do lack capacity to provide quality TB care in line with the National TB standards. The NTLP strategic plans does stipulate the strengthening and expanding of public-private mix approaches geared towards ending TB. Between the period of October 2018 and April 2019, we set up a collaborative in the districts of Kampala, Wakiso, and Mukono between 21 private health facilities, and the objective really was to establish, to demonstrate application of QI in the private sector, which in the long run will improve the TB screening and TB case finding. A baseline was carried out, which was then followed by an inception meeting, and 5 coaching visits were conducted. At baseline, really, there was no data available, and sites were not keeping a record of screened patients, OPD attendances, or even conducting a screening. We did conduct two peer-to-peer learning sessions that were held during the course of the time. And during that time, facilities did share experiences with TB screening and identification. And the learning sessions basically provided a platform for learning and enabled teams to share their packages or changes that did work. Overall, there was an improvement in the availability of data. The TB screening improved and it was sustained at 85%. And the number of TB cases that was registered or notified during that period was up to a total of 88%. However, we see a decline, a bit of decline in April. And some of the tested changes that we basically led to improvement, looking at the focus area as TB screening, and the gap was the few clients being screened for TB and the low quality of TB screening. So some of the changes included the receptionist being oriented on how to screen for TB, including the ICF guide in the triage notice, distributing laminated ICF guides to all entry points, and attaching them to the consultation desks for easy access. Also conducting one-on-one mentorship with all staff at entry points on how to use the ICF guide, and weekly review of data tools for completeness and accuracy. So whereas there is a general saying that private health providers do not want to partner with the NTP in TB control, facilities did actually appreciate the inclusion. They appreciated TB control measures. However, they feel left out on the TB program activities and are faced with a number of challenges, especially in regards to knowledge gap and capacity to provide quality TB care. The availability of tools is also a challenge, with a big high staff turnover, and hence the need for a constant engagement. Supervision and mentorships, both from the national and subnational, is really suboptimal. Some of the lessons that we learned are that engagement of private health providers really requires trust and willingness, and their engagement is really based on the capacity of the facility. And private health providers tend to work as discrete entities. Therefore, there is a need for creating formal and referral linkage networks for a successful PPM collaboration. And we also learned that motivation does not necessarily have to be monetary. Rather, other non-monetary incentives and enablers are required, such as provision of diagnostic tools, provision of sputum mags, provision of HMIS tools that are used for recording and reporting. And we also learned that there is need for inclusion in planned capacity building activities by the TB program, and this will go a long way in alleviating the knowledge gap and the high staff turnover. In conclusion, quality improvement, though traditionally used in the public sector, can basically be applied in the private sector to build capacity of private health providers, which can improve on the quality of TB care that they do provide. Equipping private health providers with TB knowledge, QI competences, tools, and improved collaboration with the national district teams improves finding TB in the private sector. We therefore recommend to scale up the QI collaborative to more private health facilities in order to improve the quality of TB care among the private health providers. And this can go a long way in supporting the national TB program to find the missing TB cases. Thank you.
Dr. Matilda, for keeping time. I would like to invite the audience and the audience online to give us some few questions to the presenters before we conclude with the first set of presenters. So your questions are welcome. Maybe we take a set, like 2 or 3, and then we shall give another round, but bearing in mind we need to be very conscious of time. So your questions are welcome to the presenters. Hopefully Dr. Matilda is still online. We shall be able to ask her. Okay. Any question? If there is any online, kindly could you come up and read it for us? And then, yes. You want to read? Okay. So the first one, they are thanking the colleagues for the wonderful presentation And the concern is community maternal perinatal, sorry. The concern is the community, thank you. Community maternal perinatal data. Do we have a maternal perinatal community linkage program in our MCH facilities? This, I think, goes to Madam Nalukenge. Oh, where is you? Okay. And then this one goes to Dr. Kenneth. Thanks so much for the presentation. Wonderful change ideas presented. And the other one is thank you, Doctor, for the presentation. Please comment on system strengthening as opposed to QI. Thank you. And I think that's all. They are not questions, but okay. The questions are the results you have presented for West Nile, the most recent results, because they show marked improvement. Dr. Kenneth, hopefully. Sorry? Okay. This, and then there's this other question from Dr. Kaita. The other first question was anonymous person. He didn't share the name. From Dr. Godfrey Kaita, how shall we have a national picture when the assessments are still voluntary and dependent on donors? We are missing a picture in regions like Southwest. What plans exist to correct this? And then the last one was, can we share these slides? Hopefully, as usual, at the end of the national annual QI conference, we share slides in form of CDs, in form of flash disks. But the questions, hopefully you still remember, you could answer them and we move on.
Yeah.
Okay, thank you.
Some questions.
Okay, Dr. Namagala.
Yeah, thank you very much for those very important presentations. My first presentation goes to the first presenter, basically about improving MPDSR at facility level within MNCH. My question was whether there was linkage of MPDSR to quality improvement and action planning. And then to Matilda, I wanted just to say that for private sector to be included is not only capacity building, but also I was wondering whether the program is also ensuring that people in the private sector have access to diagnostics, but also are supported with initiating treatment. They may not get all the treatment, because what we know, there are some patients that will never come to public facilities. And if you never scale up within the private sector, you miss them out. Have you selected facilities that can actually can help complete treatment for some of these patients as well? And it also goes to the TB program. Have you included, I've not seen much scaling up within the private sector, apart from the the missionary hospitals and all that, but the actual paying facilities, a lot of patients get TB there, and probably they take long to be identified. If you could do more, if you could be more deliberate with scaling up within the private sector, you'll be able to capture more patients, because some patients don't want to use public facilities and they will always hide in private facilities. So if you do not scale up within the private sector, there's a big chunk of patients you'll always be missing out. And it may be the link to those patients that never finish treatment.
Elizabeth, I hope you are done. Next is Dr. Martin.
Thank you very much, Chair. Thank you, presenters, especially the way you have elaborated on the process the facilities are going through to identify the problems and the interventions. I think we appreciate that. Margaret, I don't know that the question from Elizabeth was clear to you. I want to repeat the same question. People are doing perinatal and the maternal death audits. So what happened? How did it help to improve the quality or service? I think that's the key question, which we didn't get very well from your presentation, good presentation. Did it help to improve, maybe reduce the perinatal deaths or something related to that? Then the next, Kenneth, thank you so much. I appreciate the good work done by the program. You talked about the increased demand for accountability from DHOs. Maybe you can elaborate more how you managed to do that and what happened. And maybe you can also, for us to learn more how the TB interventions you mentioned, how they are being linked to the structures for QI within the district, in the first facilities, just briefly to give some light on that. Thank you.
The presenters can respond to the questions. I will move on, and you would like to encourage the people, the audience, if you are asking, to mind the time. We have a very short time. So we go by the way the questions came in. It's first Margaret, then Kenneth, and then we didn't have, did we have anything for Matilda? No? We had one. Matilda, hopefully you are still on line. You're welcome.
Thank you very much. I can see that the first question and the second question almost resemble because it is on the linkage of MPDSR to the community. It didn't come out in my presentation, but with MPDSR we are going as far as the community, because when we receive a maternal death or perinatal death, we have to investigate. We have to do otoscopy in the community. And also we are using the VHTs in case there is a maternal death in the community. VHTs are giving us, they are reporting those maternal deaths in their, at the end of the month, or even before the end of the month, and then we investigate. Actually, the linkage is there. Then another question is on maternal audit to improve quality of care. Our study was for a period of 1 year. I started that, and it started in June 2019, July 2020. So since the beginning of this financial year, actually we have not received any maternal death. However, there are some perinatal deaths. So we are hoping that the interventions we applied, actually they are working, and we are yet to see, we are trying to see whether really it worked well. But as I've said, that since the beginning of this financial year, we have not received any maternal death, and when we count the perinatal death, actually they have reduced within this period. Thank you very much.
Is Kenneth?
Hello? Yeah, thank you very much, Chair and participants for the feedback and for the questions. The first was comment, appreciation, which I really appreciate. The second was about a comment on the system strengthening element. Yes, certainly the teams to be able to improve TSR have to touch components of the health system. You need to make sure the HR is empowered to be able to provide services. There are other efforts to make sure that commodities are available, because if drugs run out, patients will interrupt treatment. The community element we are talking about, community system strengthening, usually they are community structures, but they are not supporting the TB patients. And so as we work with the regions, with the teams, we are engaging them to be able to support, of course, financing. The community teams need to be facilitated to travel, to look for patients, to support patients in the communities, and to be able to return them to care. I think among others, so basically all the pillars are quite key. The leadership is key, we hinted on it, and I want to mention here as I answer the last question as well, Leadership is key. This is one of the lessons from the field that we applied to the package. In West Nile, what they did initially was to have those dashboards, the district dashboard of TSR performance by facility. And so the sites and sites that are not performing well had to account even to the cow, why aren't they performing well? And that created some drive to be able to take action. As I mentioned, the package was developed from the problem analysis, using some evidence from the literature, but also we engaged stakeholders who are doing research to improve TSR. We have colleagues who are using technologies like 99 dots. The patient is reminded, the health worker is reminded, and so all those are part of the proposed interventions where feasible. And so that's where we got the issue of engaging the community, engaging the leadership. And then the last one on the how this work is aligned to the QI structures. So right at the front line, certainly the work improvement teams are doing the work, together with the district and regional coaches being the support. I think the area that needs to be strengthened a bit more, I think we had linkages at some point which, as the interruption happened, we need to be able to strengthen the national level collaboration, but also the linkages to be able to access, because this work is not yet in the national QI database, and we think that is one area that we need to be able to work on in the next steps. Thank you.
Hopefully Matilda is online. Is she? She has no question. I mean, I don't remember that question going to her. Just scroll a bit. Okay. Okay, so the question, Matilda, was about system strengthening as opposed to quality improvement. No. I think that was part of the recommendations.
Chair, that was mine.
Which actually Dr. Kenneth has touched. So Matilda, relax and hopefully recover soon if you were not feeling well. Thank you so much for the presentation.
Chair, there was one comment I'd omitted from West Nile, whether that was the latest result on the map. It's comparing the year before and the year that just concluded. Yes, so it's the latest. Thank you.
Oh, but there was also a question from Dr. Kaita wondering why some regions haven't been assessed.
That was for Dr. Sendiona from the earlier session.
Okay, so Dr. Sendiona hopefully will be able to. Dr. Sendiona, there was a concern, and okay, so we shall respond in the chat to that. But I would also like to share my views. One is that TB is very important in that if it's not properly treated, we are likely to get unfavorable outcomes. The one is laws to follow, and I think the presentation is working on how to improve retention so that we don't have that unfavorable outcome. The second one is about death. It kills, and hopefully the colleagues will be also looking at what has COVID done on this TB business, but we know that it kills. So we should join hands to make sure that TB is looked for, and just a mere screening by a question like, for how long have you coughed? Now there's this masking of the COVID that also presents with the cough. Secondly, is about privatization. I mean, engaging private practice. It's very important to have them on board so that the number of people who don't seek care in our public institutions should be also thought about and be able to provide quality care. And lastly, the lady is looking at me thinking I've forgotten her, is about the MPDSR, that is maternal perinatal surveillance response. It's very important because it is a quality tool. And hopefully my sister Nalukenge, you will be able to answer on the chat the results of this kind of intervention that you have come up with, because Dr. Martins raised that it didn't come out properly in the presentation, so that you share the preliminary whatever results of what has so far been achieved as far as the outcomes are concerned in terms of maternal death, perinatal death. Have they reduced? Have they? And what lessons can we learn, which we can now pass on to the other districts? Otherwise, kind the audience online and in-house join me to applaud the presenters for their excellent performance, but also for the important information they have shared with us this afternoon, morning. Thank you so much. You're welcome. And you can take now back your seat. And we would like to invite this, unlike the usual way of seeing many presenters, we are seeing one person presenting two cases, and then the other person will be Kizito Alex. So we'd like to invite Peter Mikaga, that is the second set of presenters. Peter Mikago rather, sorry for the pronunciation, and Kizito Alex to come forward. Is Kizito Alex with us? You're welcome. So Peter Mikago will be taking us through improving retention in care of low-start viral therapy clients through accelerated community drug refills. You're welcome. And the experience of Tasso Ginger Center. And then the second presentation we will be making is improving access, availability, and acceptability to tuberculosis preventive therapy among people living with HIV through the differentiated service delivery model. And then we shall be inviting him shortly after his two presentations. Thank you.
Thank you so much. Okay. Thank you so much, Chair, for the opportunity. Good morning once again. My name is Dr. Peter Mikago. I'm from Tasso Ginger Center of Excellence. Tasso Ginger is one of the 11 centers that are providing services across the country, the people living with HIV. So I'm presenting to you a project that we implemented that was aimed at improving retention in care of lost antiretroviral therapy clients through accelerated committed drug refills. And this was during the COVID-19 pandemic. So we all know that retention is critical in care if we are to optimize the outcomes of treatment. However, oftentimes, of course, we've seen that big volume facilities continue to register a significant number of clients as lost. And so this in the long run consequently affects the treatment outcomes. And if we are to end the epidemic by 2030, we need to prioritize our efforts in as far as improving our retention is concerned. So Tasso Ginger had about 61% proportion of clients that were reportedly lost. This was as of December 2019. And these were followed up to improve on the retention picture. So what did we exactly do? So we started by assigning a focal person to coordinate the different activities of retention. We all know that big volume facilities have lots of activities going on, different donor calls, a lot of data calls are also coming in from a number of people. So to prioritize these efforts of retention, we assigned a focal person to coordinate all these activities related to file retrieval, making calls, prioritizing which communities to actually visit physically. And then we also generated a monthly list of missed appointments, and these were disaggregated to the various places of residence for the clients. We also conducted a refresher CME. Now, the role of the CME was to improve on phone counseling skills among the people who were actually doing the phone counseling. And then we gave out different targets to a number of staff according to the list that had been generated. And then we improved reporting through what we called a back-to-care tool. The back-to-care tool was documenting the outcomes of retention. And these included clients who had self-transferred out, clients who were probably active but reflected as lost clients, and also possibly clients who had unfortunately passed on. So after prioritizing all those activities, the team then set to conduct multiple coordinated drug refills. And this was aided because of the different contacts of the different LRT facility in charges in the region. So in the results, we see that as of December 2019, we had about 61% proportion of the lost clients actually being followed up and getting back to care. And in the month of March, when the lockdown measures were actually instituted, we had the number actually rise up. And this is because a number of clients were not able to get back to the facility. And so the team had to devise ways of actually reaching them. In the month of April and May, the numbers reduced. This is because the team was making prior attempts of actually refilling the clients before they actually reach on the date of appointment. And in June, much of the lockdown measures were lifted, and so a number of clients were able to return to the facility after being called. So what did we exactly learn? We learned that if we are to prioritize retention activities, we need a focal person. We need a person who is primarily going to look at how activities are going to be implemented, which teams are going to call possibly which number of clients, but also seeing which areas have the greatest burden that the team needs to focus on such that we can actually keep most of our clients in care. And also, we also learned that if we are to improve retention, we need consistent data use, because data will actually guide us on which number of clients to actually focus on, but also it will help us to map out which areas are most affected that require much of our efforts. In improving retention, also, if we are to follow the cheapest approach, which is actually calling some of these clients who have missed appointments, we need updated client addresses, but also the contacts, because this will be the cheapest option of reaching these clients. However, you notice that some of the documentations that facilities have are very obsolete, and clients have either relocated or clients have moved on to new networks. And so we need periodic updates of the client addresses. And then also we need to improve the phone counseling skills if one is to engage into a meaningful discussion with the clients, and also to actually elicit the current outcome if the client is not at the facility. And then also we appreciated that significantly, if clients are away from the primary facility, we can take use of these contacts of the different RT facility in charges to actually link them to the closest facility if they can't reach the primary facility in care. So what do we recommend? We recommend that big volume facilities need a focal person or a person who is assigned primarily to oversee the coordination of retention activities such that clients can be kept in care. And also appreciate that we need routine data use if we are to follow up systematically most of these clients who are lost and actually get better outcomes. And then phone counseling and interfacility linkages are very important, because this will actually help us reach out to these clients the easiest way. However, they're important if at all they have been updated, because if clients have since moved on and some have actually changed contacts, you can't actually reach them. So we need to adopt this habit of periodic updating of our clients' contacts such that we can easily reach them. Precisely, that is it. So we acknowledge the contribution of the Ministry of Health through the Jinja District Local Government, and also TASO as an organization, USAID, and Rights EC in particular. Thank you so much.
Okay, thank you so much, Dr. Mikago, for the first presentation. So you are welcome for the second presentation. And thank you so much for keeping time.
All right, thank you so much. So the second project is about the life-saving medicine, which is tuberculosis preventive therapy. I know we've had some presentations in relation to how we can actually improve in terms of availing the patients with this life-saving medicine. So last year, the Ministry of Health set out to achieve about 300,000 people on this life-saving medicine. And the efforts were very important because the people had to be provided with the life-saving medicine to prevent them from this most commonest comorbidity among the people living with HIV. And so, however, as of end of June, the center had actually reached out to about 24% of its annual target. And so, in the acceleration of the 100 days, the best approach was to adopt to the differentiated service delivery models to reach out to these clients as fast as possible, but also to incorporate the use of the CLAD leaders and also the community drug distribution points. Like we said that TB is the commonest comorbidity, and that is well known world over. So in the methods, what do we exactly do? Thank you. So we started by generating a list of clients who had not been on this life-saving medicine throughout care. Our current number of active clients is about 7,500. So we use data to generate how many of the clients had not been on this life-saving medicine before. But also in particular, we had to map them according to the differentiated service delivery approach, mapping them according to the CDDPs, which is the community drug distribution points, also mapping them according to the facility for those who are getting drugs from the facility, which is the facility-based individualized management. And we found out that significantly would levy on the community drug distribution points, but also the CLADs, which is the community client led arm of drug delivery, to reach out to these clients as fast as possible, but also to sensitize them as much as we could. So we also conducted a refresher CME. The role of the refresher CME was to empower both the clients and staff, because these were people who were packaging this message about this life-saving drug. We all know that we have lots of myth in the community about some of these life-saving interventions. And so the refresher CME was to refresh about the eligibility, which clients were eligible for the life-saving medicine, and also what to do just in case some of the clients developed adverse events. And then we beefed up our stock with an emergency order from national medical stores, because we were targeting enrolling thousands of clients on the life-saving medicine. So we levied on the CLAD leaders to extend as much as possible the health talks in their various groups, but also at the community drug distribution points. And the teams from the facility set out to reach out to the clients because we had mapped out significantly and identified that majority of the clients were actually in community, and so these were the clients who would target first amidst those who were also coming at the facility. And the approach of follow-up was to reach these clients physically 3 months after starting. However, the CLAD leaders were doing a periodic monitoring of these clients, but also reporting promptly if at all NA is developed after these clients starting on the life-saving medicines. So we noted that we moved from about 30 to 93% as of end of September. The significant improvement was in the month of August, where over thousands of clients were enrolled on the life-saving medicine. And why so? It's because both the clients, the CLAD leaders, and the staff were able to competently sensitize the clients as much as possible, especially in the community drug distribution points, but also the CLAD groups, because these were fellow peers, and their message was well packaged and easily appreciated by these clients. And so in the month of September, I think about 800, but this is because much of the numbers had actually significantly been reached upon. Okay, next. So what did we actually learn? That access and acceptability of this life-saving medicine can be improved, especially if we adopt the differentiated service delivery models. Why so is because during the facility-based individualized management sessions or facility approaches, there are lots of activities that actually are taking place. And so mapping out these differentiated service delivery model approaches can tailor the intervention as quickly as possible, but also using the existing possibly C-clad leaders and expert clients who are supporting the staffs. And then we need a good working relationship if we are to enable task shifting, especially among these expert clients and linkage facilitators. And they can actually support these clients in as much as counseling is concerned, in as much as making follow-ups is concerned, so that they notify the healthcare workers or the staff to also make prompt interventions in supporting the clients as early as possible. And so what do we recommend? We recommend that we bring close the C-clad leaders and expert clients to enable them continue the sensitization, especially about some of these life-saving medicines, that they will reach out to the clients as fast as they can, but also they quickly ensure quick buy-in of the service, especially if they are involved in sensitization, conducting health talks, but also in noticing if there's any side effect that needs to be reported to the healthcare workers. And then we need high volume facilities need to embrace the DSDMs that has been emphasized in the quality of care presentation. If we are to serve these clients with a quality service, we can't really do away with the DSDMs. It's the best way to go, and so we need to adopt as quickly as we can. And then C-clad leaders, like I said, they need to be incorporated in service delivery, because they will quickly support the staff in instituting the DSDMs approach. Thank you so much. And again, acknowledgement. Acknowledgement is from TASO, Ministry of Health, USAID, and Rights EC. Thank you so much.
Thank you so much, Mr. Peter Mikage. You have made my day, because I was worried. I was reminded by the colleague that we are time-bound. But he has made it, and hopefully my colleague, Kizito Alex, will also do the same.
Thank you, the Chair.
Kizito Alex is taking us through, is focusing on utilizing community structures to improve first ANC attendance at St. Francis Mbirizi.
Mbirizi. Thank you. Kizito Alex, a registered comprehensive nurse from St. Francis Mbirizi, Health Center 3, Rengo District. We are utilizing community structures to improve first ANC attendance. And first ANC attendance, we are targeting less than 14 weeks. Specifically, this is an opportunity for early diagnosis, prevention, and treatment of problems that may be related to pregnancy. Community mobilization and education are usually key as a package for antenatal services. So this provides a foundation usually for effective participation of the community, which is usually evidenced by increased uptake. Thank you. Ministry of Health recommends that 98% of pregnant mothers should attend their first at least 8 contacts or visits, and the first one should happen in before 14 weeks of pregnancy. That was WHO recommendation 2016. However, at St. Francis Mbirizi, we were able only to have 20% as of May 2019. As a department, ANC department, we went ahead to develop interventions to see that we can improve to at least 60%. Next slide. In our methodology, we went ahead to have a meeting as a department, and we are able to identify gaps. Okay. we are able to identify gaps, and specifically we identified as inadequate sensitization, influence of TBAs, few skilled VHTs, lack of support from male partners, and transport costs as root causes to why mothers are not attending their first antenatal before 14 weeks. And we strategize to have community meetings, and through these we strategize to have community meetings and using this to do sensitizations. Sensitizations were done at village levels, and through these meetings, not only village levels, we also had meetings at places of worship, marketplaces. We also had discussion. During these meetings, we conducted group discussions, as this also could help us to know what else we could do to ensure that this is achieved. We also went ahead to sensitize VHTs and LC1 chairpersons on the importance of timely ANC attendance. That is before 14 weeks. We also went ahead to pin up posters with information on the importance of timely ANC, and we distributed flyers in the community and where people can find this information, such that more people are able to get the information, and maybe, probably, they would know the importance and then attend. And those are our results. You can see a steady improvement with increase in sensitization. You see, proportion of pregnant women attending first ANC within the first weeks improved from 20% as of May 2019 to 62% by February 2020, specifically due to involvement of community structures, which increased sensitization and mobilization. Sensitizing households would improve ANC attendance and hence improve utilization of services. Sensitizing VHTs and LC1 chairpersons would instill trust among the households within the community, which later improves ANC attendance. We conclude that sensitizing women and men through community meetings greatly improves ANC attendance within 12 weeks or before 14 weeks. We recommend that government and development partners should invest heavily in community structures to increase knowledge about ANC services, which improve timely first ANC attendance. We acknowledge St. Francis CHI team, facility staff, Lengo District Government, Uganda Catholic Medical Bureau, LACA ES Sciences Program, Center for Disease Control, and the Ministry of Health for support. Thank you for listening.
Okay, so colleagues, thank you so much, the presenters, Dr. Alex, is it? Sorry. Dr. Peter Mikago and Kizito Alex. Now it is our turn as audience to ask some few questions for clarifications, maybe for the interest of the other people in the communities to benefit from the lessons learned. We would like to find out, maybe before the audience asks questions, we needed to seek clarification on some whatever issues that didn't come out clearly. Is to do, maybe for myself, is to do with the clarification on this, was it a delivered service model, differentiated service delivery model, or was it a community drug refill? That's for Peter. And the second is for him. Was it a first ANC, or was it first trimester in the first visit, the first ANC visit? So if you clarify on those, then the audience can ask questions which are relevant to that. the presentations which you made. Peter, you want to go first?
Thank you so much. I think the clarification, the first project was about retention, and we all know that during the lockdown measures, a number of clients were actually unable to reach the facilities. And so the approach was through community drug refills. And in the community, I would work with some of the CLAD leaders, but these refills were accelerated and actually coordinated. And so some of the clients were actually served before the days of appointment in attempt to actually retain them in care. Yeah, and then maybe just for, again, more clarification about the IPT project. So the service was basically through the community differentiated service delivery models. And whereas some of the clients were started on TPT were from the facility, but like we saw in the results, over 80% of these were actually served in the community. And the reasons for so were that these CLAD leaders did very good work in terms of sensitizing of these clients and screening, but also monitoring their adherence on this life-saving medicine.
Thank you, Chair. It was first ANC in the first trimester, because first ANC before 14 weeks of pregnancy or gestation.
So according to the audience, sometimes they want to say first trimester, and that is the time between conception and the first 14 weeks.
Yes.
Pregnant. Okay, thank you. Would like to give chance to the audience internally, and then we go to the colleagues online, or we do the other way around. So as we wait for the questions within, would like to thank the colleagues online who were able to send some messages of appreciation, but also questions. The Awidi Jenny, that MPDSR presentation, what did the team do to curb the causes of death from the community? I think this was meant for the previous whatever presenter. Hopefully she will be able to, if you now can get you, are you able to access online? You can respond to that. The question was, what did the team do to curb causes of death from the community? And then I think it is all about, it reminds us about the needs to come up with actions during those audit meetings and be able to take action. So we have also a colleague called Martin Mugisha. Peter Tasso, thanks for the good presentation. Please kindly elaborate on the phone counseling, since some clients are elusive to communicate on phone. How is this done? What motivates the team to review data and do periodic updates? How often is this done? Peter, is that question clear?
Yeah.
And Martin Mugisha again says to Peter, IPT first dose, IPT, does this medicine IPT clear latent TB? So after, how do we repeat this medication? How did you address the myth about IPT in the community? Do we have any data at facility level showing a decrease in new TB cases? This question, is very important for the ears of Dr. Kenneth Mutesasira. I mean, Peter, you are going to respond to this, but I think it sends some messages about IPT. No. They are answering. They are going to answer. So, Peter?
All right. Thank you so much once again. He says, why was phone counseling important? Now, like we said, it's the cheapest way we can actually reach out to these clients. However, it is dependent on having a very updated contacts of clients. Otherwise, if you don't have the updated contacts, it seems not to be so much useful. And why was it important or how was it done? Like we said, we had to have a counseling session, more or less like a continuous counseling session of sorts to give out the basics of a good phone call. We know that in most of the big volume facilities, many of actually the staffs are carrying out a number of activities at the same time. And so if we are to make a good phone call, we need to make a very good introduction to some of these clients, but also noting on how this client was actually initiated on ERT at your facility. Did the client wish possibly to be addressed as such, or the client possibly wish to be addressed by healthcare workers as a colleague? So all these different dynamics had to come into play in terms of how to approach a difficult patient on phone, but also how to get the exact message, because the intent was to find out the true outcomes of the follow-up attempts, whether this client is actually still active, or whether this client is actually self-transfer, whether sometimes we may actually not get the client, but we get the next of kin, whether this client is actually still existing. So the dynamics were basically into making a very good, comprehensive call, like how to handle the different clients in the different scenarios. And then how often or what was motivating the team? What was motivating the team was that many of the clients were actually not coming back to the facility during the lockdown measures. And so, but we also know that the physical follow-ups are really very expensive. If you had to use cars, if you had to use motorcycles to reach out to the different clients in the communities. So again, the cheapest really is by first beginning with a phone call, although, like we said, this is only useful if we have periodically updated many of these clients' contacts in the different documents that we have. And then the other was, how did you address the myth of IPT in the community? And we said that we started with the refresher CME. Many of the staff also may have inherent myth about these life-saving medicines. So we started with that refresher to find out who is eligible, and then also what are the commonest side effects, or what to do with a client who reports a suspected side effect. And so, but again, we know that the buy-in, if at all these community clad leaders are well sensitized, they quicken the buy-in process because they are speaking to fellow peers. Some of them are involved in really basic counseling of these fellow peers. So they have that group adherence that they significantly play in ensuring many of their colleagues actually embrace the intervention. Then in terms of the cases, yes, we have noted some decrease in terms of the TB cases at the facility, which could be attributed to the scale-up of this life-saving medicine.
Peter, I think there is a question which I haven't heard you responding to. Was about, from Martin Mugisha, does this medicine IPT clear latent TB?
Does the medicine clear latent TB?
Mm-hmm. And so that's why I said this question has some messages to Kenneth.
Let Kenneth first give, I think, some response.
Yes, thank you, Martin, for that question. Yes, the medicine clears the latent TB, and studies on the duration of protective effect are still ongoing, but currently what is known is that once someone completes the course of TPT, for at least 36 months, other measures being observed, they have a protective effect. But as a country, we have not yet started the repeat dosing for TPT. Thank you.
Okay, thank you so much. You didn't have a question. That means your presentation was clear, and that means also maybe the members didn't do what? Didn't think about what else can be asked. But we just want to emphasize the point that nationwide we have a problem of first trimester, the percentage is not so good. And we know that that period is very critical in terms of the baby growing in the womb, and there's a lot of associated birth defects. And therefore, it is very important to copy from the colleague to make sure that what has worked in Mabirizi can work elsewhere if we engage community. WHO has added a 9th standard on the quality of care standards. And these quality of care standards include evidence-based treatment, effective referral, communication. We have HMIS, we have motivated staff, we have infrastructure, we have emotional support, we have preservation of dignity and the privacy. And so the 9th one is now community. We are finding it is very important to have community on board to be able to reach out to the mothers. And this will hopefully be able to improve on the services and the outcomes. So, colleagues, if there are no more questions within, okay, there is one there. Kindly, we are short of time.
Thank you very much to the two presenters. My name is Dr. Anna Lawino from Rights North Acholi Activity. My question goes to Peter on the second presentation you made about using the differentiated service delivery models at community to improve initiation of IPT. Now, we know that there are a number of side effects that have been associated with initiation of isoniazid. So I wanted to find out from the community models and also looking at the people who are delivering these drugs, mostly the clients, what have you put in place to ensure that pharmacovigilance for the side effects or the adverse events were monitored, if there were any, in these community models? And then two, you clearly elaborated to us the results that were mainly looking at increment or increase in initiation of patients on IPT. Could you tell us what the picture is like for the completion of the treatment? Because we know that it has been a challenge. So we want to learn if in this model we see completion rates improve as well. And then lastly, just from the first presentation you made and the second one, since it looks at differentiated service delivery model, just to share with us what are some of the motivators for these people who are picking the drugs and delivering them to fellow clients in the community. What motivates them? How do they handle the issues of transport challenges or just motivation to do this work? Thank you.
Okay, thank you. I hope you have taken it. And maybe I can give you as well this so that you, this goes to Kizito. Kizito, you have, how were the community structures motivated to conduct the activities? Are there incentives? If so, what are the sustainability plans for more first ANC turn-up? And then the other one was, how easy was it for your VHTs to identify the mothers in the first trimester? And to Alex still, so Alex, you're lucky. Towards the end, you're getting more questions. ANC in first trimester is from conception to 12 weeks as per MOH guidance, and not 14 weeks as you stated. So that was a contribution towards knowing the exact definition of this first trimester. So hopefully, colleagues, you have got the questions. You can respond. We start with Alex as you. Okay, yes.
The first question was, how were community structures motivated? At first, we never had anything to give to these people, but we made them own this. We made them know that this was important for us because we also many were brought on board. Sensitizing VHTs and LC1 chairpersons was to make it that if the reader is aware of the importance, also the subjects will be able to follow. And what were the sustainability plan? Still, there is continued desensitization. Also, at the facility, we are continuing with health talks as mothers come in on the antenatal, on the clinic day of antenatal. We continue to sensitize, and we don't miss any other opportunity that is available. Still, training the VHTs and LC1 is also part of our sustainability plan, because this will continue to pass on information in the community, even in our absence. Thank you.
The other question was, how did they diagnose the
How
mother?
did they come to know that this mother is pregnant and in the first trimester?
Given the cultural beliefs that you don't reveal to people about your status until there is a protrusion of this whatever abdomen.
Yes, I think the world is changing. In the community, there are still some people who find it hard to reveal that they are pregnant, and there are those who find it easy. So some reveal, and that's why we are not yet there at 98%. And our aim was at 62, because still there are challenges which still hinder this.
Okay, but Alex, for purposes of helping the other communities,
Yes.
we need to teach the VHTs some basics. There are some signs that we can use to tell that this mother is probably pregnant.
Missing periods?
Yes. Okay, so colleagues, I would like to request to join me in applauding these colleagues of ours for having shared with us very excellent presentations and the experiences. Join me in applauding them.
So,
Okay,
Mr.
thank
Chair,
you
maybe,
so much.
Maybe just a few responses to some.
Oh, I've missed one thing there. Question.
Okay, yeah, briefly, she was trying to ask, inquire, how did we do pharmacovigilance?
Okay.
Yes, so we said that the community has the community aid support agents, or whom some people might call the CCLAD leaders. And so before actually starting on this project, there was a CME, a refresher among these CCLAD leaders who were going to support. And then too, as the facility staff set out to meet the various leaders, we had to do, the staff had to leave their contacts for a quick phone linkage, really, if at all the CCLAD leaders suspected that these clients' complaints were related to a possible adverse event on AE. But also using the existing contacts of the different facility in charges, if the staff was really not able to reach that client that particular day, would link some of the clients to the nearest facility. And then the other issue was that the physical follow-ups were done 3 months by the staffs, unless the client really was suspected to have a major AE and would not reach maybe the nearest facility. So we used those methods. One was leaving contacts of the staff that CLAD leaders would call if at all they really suspect that the client has an AE. And then we would also link some of the clients to an immediate facility if at all we really suspected so. But also most importantly, at 3 months, if at all there was really no major adverse event, staffs had an opportunity to interact physically with these clients during the course of treatment. And then the other was about completion. The site was audited by USAID about the completion rates, and the completion rates were really good. Of course, we got some clients, I can't exactly tell the percentage for AEs, but there was really no significant, there was improvement in terms of completion of this life-saving medicine. Then the other inquiry was, what motivates the CCLAD leaders to actually carry on this heavy task of screening, of carrying on peer counseling, of monitoring for AEs, but also reporting the adverse events to the staff. So for a starter, they were being given a transport refund that was supporting them to reach out to the different CCLAD members. But also, these are people from within the community, because the CCLAD is a composition of about 6 to 10 and some of the clients actually coming from the same catchment area are being reached on by this very individual. So the aspect of community service also is incorporated in, but like I said, there was a little motivation of a transport refund during this process.
Maybe, Peter, related to that is we've not known whether you had the challenges accessing pyridoxine. It's related to what she was asking about the pharmacovigilance.
Accessing drugs?
Pyridoxine.
Pardon?
Vitamin B6.
No, the facility was well stocked. We really had an emergency order and it was responded to.
Thank you so much.
Yeah.
Okay, members, join hands in clapping for the presenters for the excellent job done. And Peter particularly had 2 presentations made. And my colleague from Rubirizi, thank you so much for the presentations and wish you well. But I would like to encourage the members, if they can be further supported to develop some papers and you publish, would be very important. Sometimes, quite often, we end up in this business and until December is when we listen to others. But yet, excuse me, we haven't been reading what really was presented in these conferences. So we need to have a culture of developing papers and people from different parts of the world read them. But this we have been privileged to have colleagues share with us. The theme was governance, and we know very well that governance is the practice of the different stakeholders that provide service. And depending on how they make decisions will certainly affect the population. And so you've heard the colleagues came up with some QI projects that were evidence-based, and they also had time to think through what could be the real problems, and the decisions they made resulted into some improvement. And we are always reminded that the very key duties under governance is the oversight, strategic planning, decision-making, and the financing. And so all these put together, I think there were elements that were mentioned under those different duties of governance. And we would also want to remind members that as soon as we are done with our lunch, we would like to be reminded of the very special event that will be coming. And hopefully my colleague can take over. Thank you so much for the participatory audience and also the support to the presenters and the questions that enabled them to improve on what they wanted to share with us. Thank you so much again. Wish you well until next year.
Let's give another round of applause to Dr. Ibrahim Chilunda for moderating this session. Thank you so much. And of course, another round of applause to the panelists who made our late morning and early afternoon enjoyable, and of course, a learning experience. Ibrahim, I've talked about the issues of publishing papers. I think that's a weak point. We do a lot of work. We have a lot of lessons to learn and things to share, but somehow we are a bit weak on publishing. So I think it's a word of encouragement from the session chair. Let's write. However much you always just document those drafts, you can always pair up with the people you have already mentioned in your presentation, and you write something, and we get these credible journals, and of course your CV is enriched. So we have come to the end of our breakout sessions for the 7th Annual Quality of Improvement Conference. In the afternoon, like you said, we have the closing ceremony for the conference, and we shall be here at 1:30. Our online delegates, the closing session starts at 13:30 hours, or or 1:30 p.m. East African Standard Time. So we shall be here to witness the closing. So we are breaking off for an early lunch. And please just respect the time of reporting back so that we start on time. The online delegates, the IT will see how to keep you entertained. But just in case, since you know that we are opening at 1:30, you can always log off. But before you log off, we propose that please activate your videos and photographs so that they can take a snapshot of all those who are online. Please, online delegates, activate your photo shoots of videos so that they can take a shot of all those who have attended virtually so that we put it up in our report. Please activate your videos before you log off. So bon appetit, let's come back at 1:30. Thank you and cheers. Online delegates, please activate your videos because we want to be viewed by the team here, as well as to take a snapshot, a screenshot of those who have attended our conference. Please do the needful because we need you for our report. We need to see, to attach faces to the names we have been seeing in the chat, because some names are phone names taken off 15, Samsung, but now we need to see the actual faces. Thank you. It's very good. At least those on the first sheet could all activate. Director Joseph, nice to see you. Online delegates, don't worry about your data. Just turn on the video so that we can see you. Don't worry, we want to see you. To take that screenshot with everybody visible for our report. Thank you. Okay, thank you very much, online delegates. At least we have captured you. See you soon, Director. Director Joseph in the afternoon at 1:30. And to you all, let's meet at the closing in the afternoon. Bon appetit and have a nice afternoon. And those of us who have to go for Juma prayers, you can go, but be sure you are around for the closing.